Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Medical guidelines often look technical from a distance. A new recommendation here, a revised sequence there. But sometimes, if you listen closely, they reveal something bigger. A field changing its mind about how urgently it needs to act. This is what is happening in the updates to the ACR guidelines for juvenile idiopathic arthritis, or JIA. One major shift is in systemic JIA, where the field is moving toward biologics first, rather than slower, stepwise treatment approaches that may delay effective care for too many kids. In non-systemic JIA, the guidelines create more room to tailor treatment to how severe the disease is and which risk factors a child has, instead of pushing every patient through the same sequence before escalating. And beyond medications, the guidelines also take a broader view of care, with more attention to mental health, physical activity, rehabilitation, and the realities of growing up with a chronic disease. So this episode is not just about what changed on paper. It is about a deeper shift in philosophy, treating earlier, tailoring faster, and taking more seriously the full life of the child behind the diagnosis. My guest today is Dr. Karen O'Neill, the lead author of these guidelines. Dr. O'Neill is a pediatric rheumatologist, chief of pediatric rheumatology at the Hospital for Special Surgery, and professor of clinical pediatrics at Weill Cornell Medicine. She's widely recognized for her work in JIA and other pediatric rheumatic diseases, and for helping shape evidence-based national guidelines that inform how children with these conditions are treated. Enjoy. Karen, welcome back to the show.
Thank you so much for having me.
You know, it wasn't so long ago when we had you to talk about, I think it was 2021, the JIA guidelines. And now you're back with updated guidelines.
I know, and it's a lot of effort. So it's a really good question to think of why we're doing this. And the reason we're doing it, you might ask, is because although we wrote guidelines in 2021, it's true, the poly guidelines are from 2019.
Uh-huh.
And if you look at treatment since then, we have made a tremendous amount of changes. So in advance of moving towards more of a do guidelines when something new actually happens, as opposed to just revisiting the entire project, what we decided to do is bring everything up to the same point in time.
So
This is actually
2025.
a huge project.
It sounds, there's going to be tons of papers published from this amount of work. And I truly believe that this is a lot of work. When did you guys start working on these revised guidelines?
In some ways, really right as we were finishing the last ones, because it was clear as we were writing them that they were super different than the 2019 guidelines. And so because the structure of what we did, the way we parsed things were very different, that it was sort of a desire to want to bring those up to where the others were. We took about a year off, and then we started again.
And then started working. And so talk a little bit about sort of the groups, who was involved, how many groups were there, and who were the participants that made up these groups?
So I have to say that, first of all, it takes a village. Second of all, I'm going to tell you these groups in order of importance in some ways. So the first, of course, are the ACR professionals, because I have to tell you, without them, this can't be done.
Yep.
That's the first thing. You know, we get distracted. There's so much going on, et cetera, but they keep us on track. And so can't do it without them. Same with the librarians, the people who actually understand literature searches. And finally, the third group, which you cannot live without, are the people who do the literature reviews. Someone has to go through all of the articles that fit under the search terms as helped by the librarian to read them all the abstracts, and decide, is this an article we should extract? Is this on point? Or is this not on point? But that means someone has to read each and every one of them. And I would say that our literature is certainly not voluminous like rheumatoid arthritis, for instance, but there are a lot of articles on point, not on point, and we have to find them and extract each and every one of them. So those are the three groups, I think, without which you cannot write a guideline.
Amazing. And then how many were there separate groups for each topic of the guidelines?
No, there was a group that did literature searches. We sort of let people direct if they had a content expertise,
Mm,
perhaps, but we're really reading the literature reviews point is to just extract them generically. In other words, what does the article say? What does it show? What's the population, et cetera?
got it.
And so then we put together this evidence report. And from the evidence report, the core team and then the voting panel are going to move forward. So the core team, again, with whom this cannot be done, it is a major time commitment. Included here, Susan Chenoy, who was lead on the systemic topic, Dan Horton on the non-systemic topic, Sheila Angeles Hahn on the uveitis topic, and Rich Fahey, who stepped in on the non-pharmacologic manuscript. And so they really spearheaded all of these with me. And then we generated sort of the scenarios that we voted on based on the questions that really had been established before the 19 guidelines.
Mm.
What to do? What's the first line treatment? What's the second line treatment? What do you do if it works? What do you do if it doesn't work, et cetera? And then the voting panel votes. And that is very, very interesting.
Tell me a little bit about the quality of evidence that you found. As we were talking before we started recording, this is not rheumatoid arthritis, where there may be literally hundreds of trials. This is juvenile idiopathic arthritis, I assume less evidence. So how high was the quality of evidence?
So, the first thing to consider actually are the two different ways that most people study the quality of the evidence. So RAND, which is what we used to do, really starts with the randomized control trial is the highest, and then so on and so forth till you get to case reports, or not count case reports, but whatnot. But that's actually not what we use, since that's not what we did in the 2021 guidelines. We've moved to something called GRADE. And GRADE not only takes into consideration the level of evidence. And yes, the evidence is low. It's mostly very low or low. There was a few moderates, but no very high. But it also takes into consideration patient preferences,
Mm,
physicians' preferences. So in other words, the data says X. Is that something we should always be doing? Is there wiggle room and it might be mostly the right answer, but not always the right answer? Would every patient want to do this? Does everyone have this available? And so
mm,
taking all of those things into consideration. And part of that is to remember that these are guidelines from the American College of Rheumatology. So they are very specific to the management of children with JIA and uveitis, secondary JIA, in this area,
mhm.
because they take into consideration what is available. Does that affect certainty? Would you always do this? Well, the answer would be not if you can't get it.
Super interesting. And you sort of hinted at how interesting the voting was. Why was this so interesting? Was there a lot of debate?
Well, I think if anybody spends any time with our community, it's quite small, obviously much bigger than it was. And yet we're very comfortable with each other and we're quite comfortable with arguing thoughtfully. And so when you're doing your voting, it is to some extent groupthink because we're
Hmm.
doing it in the moment. And so there's a lot of wordsmithing. There's a lot of, but I disagree. These are consensus, but these are not where everybody agrees. But it's what we can live with. Can you live with this?
Hmm.
And if everyone doesn't agree, then it's probably not a strong recommendation because people can't agree. Like I said, it's a thoughtful process, listening to people. And I think we get a sense, we know each other, we have a sense of what people might lean towards, but you can't always predict.
Very good. Sounds like a lot of compromise. I feel like people in Washington
Yes.
should should get some ideas from the work you guys are all doing. Let's get into the guidelines, starting first with systemic JIA. So let's talk about some of the major changes. So with somebody presenting with, active JIA, how should we think about treating them?
So this is clearly a move over time because if you go back and look at the 11 and then the updates in 13 and the ones he wrote in 21, NSAIDs still existed as part of this. Even in 2021, when I think a lot of people felt strongly that we didn't necessarily want to have NSAIDs as part of it, there was literature saying that 20% of kids did get better. And so we included that as an option. And this time we really strongly said no. That first line therapy for systemic JIA is a biologic, either an IL-1 or IL-6 inhibitor.
Yeah. Yeah. And that's a big change, taking the NSAIDs out of it. And I guess
Yes,
there's no preference between the IL-1 or IL-6 inhibitors as
that's
first
right. We're
line.
still in the position where we can't say. I can say that when we did big studies for us, which was part of CARA, most people or many people choose an IL-1 inhibitor first, but you could be in a situation where in your hospital, IL-6 inhibitors are what are available, and that is perfectly fine.
Hmm.
This is an accessibility issue, but there's no data showing that one is better than the other. So we left it open to the practitioner.
What should we do with people that don't respond to that first initial biologic therapy?
In that case, I think you have to think about it in a few separate ways. If they don't respond at all, we would suggest flipping to the other. So if
Mm.
you started with an IL-1 inhibitor, switch to an IL-6 inhibitor and vice versa. If you have persistent arthritis, but the systemic signs are well controlled, then adding in things like methotrexate might be appropriate. Treating the arthritis, joint injections, etc., would be reasonable. But the question of what to do about persistent systemic signs where the patient doesn't have arthritis, that's a little bit more open to conversation. You have somebody who has gone through an IL-1 and IL-6 inhibitor, and that is where it really depends on, is there at all MAS? What are the kind of things that we can do? Should we be considering a JAK inhibitor? And so
Hmm.
that's new, just having JAK inhibitors as part of the dialogue of what you would do at this point in time.
Interesting. So not necessarily as first line agents, but sort of rescue therapy if they fail IL-1 and IL-6 inhibitors. You
Yes.
mentioned MAS. Any big
Yes.
changes with the management of MAS in these patients?
So the biggest change for MAS is that we have a new drug. So first of all, JAK inhibitors are certainly part of the dialogue, but I think we have to address the issue of emapalumab. And so emapalumab was approved not long ago,
Yeah.
actually after the voting panel
Yeah.
meeting.
This year,
Yes, for the treatment
2025.
of exactly this, systemic and JIA-associated MAS. And so we didn't really get a chance to hash out exactly where it would fit in. There was some discussion about it replacing calcineurin inhibitors. Other
Mm.
people felt strongly that calcineurin inhibitors would be first, but we didn't address this at the voting panel.
Hmm.
So what we said is it's there. A very sick patient who needs it should get it. But exactly what order
Mm.
all of these things should be is really still open for evidence, studies, and what's available to you. And
Yeah.
since like I said, we weren't able to discuss it in person, we deferred, similar to what we did last time when tofacitinib came out right
Mm.
before the journal. We included it, but we didn't say when it should be used.
Interesting. So this is really up to date, and you were sort of predicting what was going to happen
She's hot
with
off the
with the
presses.
treatment. Another change, systemic JIA associated lung disease.
Yes.
How should we think about screening patients, and should we screen everybody?
So this was, again, as you would imagine, a serious conversation. Similar to the last iteration on systemic J, we decided that these drugs, for most children or many children, are really life-saving. And we remember what it used to look like when patients were on steroids all the time and having hip replacements at 10 and all kinds of
Mm.
things. But we recognize the severity of this. And we thought, should we restrict screening only to people who, for instance, might have particular characteristics. They're quite young, they have persistent MAS, et cetera. But what we realized is that we actually don't know truly who has what. And the truth of the matter is all these kids should be screened. What we couldn't really agree on is the way that they should be screened. Because again, that depends on the age of the patient and local customs. PFTs might be great, but not for a very small child. And so, we need to obviously include our pulmonary colleagues, but the question of whether or not to get chest CTs on everybody, especially low radiation chest CT, is certainly out there for discussion, and especially for a high-risk patient. We need to find what the best way of screening is, but the problem is it really is age and also local customs, what you have available to you. But more to the point, what we said was that the presence of lung disease itself was not a contraindication to continuing biologics. There are some people who believe that that's true, but again, these children are individuals, quite sick, and until we have the answer for everybody, which, as we know in our field, is unlikely to be ever a change, then we have to go ahead and treat the patient. And so we cannot make absolute lines, nor should we.
Interesting. And let's go to the sort of the other end of the spectrum. You have somebody with systemic JIA who's doing really well. I think the fact that we're using biologics right up front makes, remission much more possible for these patients. So you have somebody who's been stable. What do we do?
Again, this was something we had a great discussion about, and this will be true across the board, every single subtype of arthritis, which is we could pick a number. We could say 3 months, 6 months, a year, et cetera. But really, this is a biology issue. So the question is whether we'll get biomarkers. Should we be checking CXCL9, IL-18, et cetera? Would we be able to get a sense at some point of when it's actually gone as opposed to treated? And maybe 3 months for some kids is right, maybe 6 months, maybe a year. We couldn't actually get a number because actually there is probably no number. So I think most people felt that fewer than 6 months was probably too soon. But in any individual patient, I think until we know the biology, we have to be open.
So you're saying that we should wait, there was no consensus, but maybe waiting at least 6 months or longer, ensuring that the patient has achieved remission before thinking about tapering. Or I think one word that I read was deprescribing.
Yes. So that is a really uncomfortable word. And thinking about Dan Horton, who has brought this to us from the epidemiology world, I always say deprescribing. I hate that word. But it is the proper term, actually, for taking medicines away, which is an active term. We prescribe and we deprescribe. And so we did have to address what would happen if you flared. We know that some children have monocyclic disease. You can get them off and they're fine. And then some it will come back. And so if it comes back, we restart the drug that most recently worked. And in this recapture studies, most of the systemic patients were able to be recaptured on the same drug. If not, it would be the same thing. You would switch to the other biologic, et cetera.
And how should we think about deprescribing, to use that new term? Should we stop drugs altogether, or should we try to taper over time?
If we really want to answer that question, we're going to have to think about this study in a very complicated fashion. I think most of us taper, but the truth of the matter is the way the studies are done, if you think about when you stop versus when you taper, if you taper, you have medicine exposure months later, even though you're on a lower dose. So the time to flare, what's actually the time to flare? It's from what point? When you started tapering? Right? So until we really can figure out a way to address this, and especially until we have biomarkers, I think this remains an unanswered question. That being said, those of us who remember life before, when we started down at Kinra, there were people who 23 and a half hours after the dose would rash again. So I think we do get some clues, when doses are delayed and things like that. There are people who are still very reliant on them.
Great. Let's move on to non-systemic JIA.
Yes.
I think one of the sort of main themes on this is thinking about sort of customizing therapy depending on your patient's risk factor. That was mentioned. Tell me about that. When somebody has non-systemic JIA, what can I do to try to risk stratify them?
This actually might have been the most useful thing that we said in the last manuscript, because one of the specialty pharmacies actually took that recommendation about risk factors and put it as when you were trying to escalate therapy, does your patient have any of these risk factors? So I do think it's important. And there were a number of them that we identified. Remember that non-systemic JA is a broad array of diagnoses, including rheumatoid factor positive and negative, polyarthritis, extended oligoarthritis, psoriatic, enthesitis, et cetera. So this is a wide array. So these were the things that the literature really supported as risk factors, which was involvement of the wrist and the ankle, involvement of the sacroiliac joint, hip, or TMJ, presence of erosive disease, delay in diagnosis, elevated inflammatory markers, rheumatoid factor or CCP positivity, and symmetric disease. And these are things that should escalate therapy. But I think even more so, what I'm most proud about in this new manuscript is similar to what we said in the systemic paper. You have a patient in front of you who comes in and has any of these risk factors, many of these risk factors, or rapidly accelerating disease. You need to start a DMARD right away. But we do not specify that a conventional synthetic DMARD is always correct as first choice. What it said in the last paper. And what was interesting about the last paper, the 2019 paper, was because of cost reasons especially, the tie went to methotrexate. As a conventional synthetic, it's first line. But there was a notation in a parenthesis set that said, although the parents and patients disagreed. The parents and patients, honestly, universally were in favor of early use of biologics because they found methotrexate to be an intolerable drug. But more to the point, we have data from the Stop JIA trial that shows that early combination decreases the time, the window of disease activity. And that has effects. Because if you said to me, okie dokie, both medicines will work, but won't work for 6 months. So you won't be able to go to school because you can't walk. You can't play soccer. You can't do any of the things that you as an adolescent is supposed to be doing. Or you can have this other drug, which is more likely to work fast. I think we have to take all of these into consideration. And in this paper, we very much come out strongly. There is not a time frame. You don't need to try something for 3 months. If things are getting worse, accelerating therapy is appropriate. Treating patients for the severity of their disease is appropriate. It's what the children need, deserve, and what we as their practitioners strongly stand behind. And that's what we said in this manuscript, and I'm very, very, very proud of that.
Got it. But you didn't go out and say first-line recommended treatment is biologic or combination therapy.
So I might have moved in that direction myself. Not everybody agreed about that, I think. And there was some concern, which is interesting, that we can't always get the combination. And if we made that a strong recommendation, people felt somewhat awkward that they weren't going to be able to have it. So baby steps, but I would bet money that changes the next time we go through
Next
this.
recommendations. Awesome. And then another thing that I read that was interesting is oral methotrexate over subcutaneous methotrexate. Was there a lot of discussion behind that decision?
Oh, yes. And including at the ACR meeting.
Yeah.
So it's very interesting when you're a principal investigator of a project. The paper gets written by many people over and over and over and over again. But you're allowed to sway things in a certain way. In the last iteration, which we carried through to this one, my general feeling was that timeframes are not helpful when you have a child who can't walk. And that, we have to just move things ahead. Also, basing things on, I think it's more active than others, is an arbitrary management. Because if you have risk involvement, if it's really bad or if it's mild, it's all really bad. Trying to get to the fact that these diseases are serious, and when people present with these certain characteristics, we really want to scale things up. So for me, honestly, as a practitioner, I think methotrexate is an adjunctive medicine. If me personally, if I could give everybody a biologic up front, I probably would. They're effective, they're well tolerated, and they prevent bony destruction in kids who still come in devastating conditions, something we should never see. That's my personal preference. But this is a consensus. I understand that. But in my mind, if it's really an adjunctive therapy, and actually we strongly state that we think the two should be used together for synergy and prevention of antibody formation, then the dose of methotrexate and the way it is given is sort of less of an issue because I don't think we know what the dose is for adjunctive therapy, right? So for me, I actually thought that this was a small part of it. It is certainly the thing we argued about the most. Here is what I would say about it. And I really have to credit Dan Lovell for being my backup in this. And no one, in the United States, he certainly knows the literature as well as anybody. We will all say, it's said in the 19 paper, and I think if you polled 100 rheumatologists, 98.5 of them would say subcutaneous methotrexate is better. Now, what does that mean? Because actually, that's not necessarily true. Does it mean better tolerated? That might be true, but it also might not be true in any individual person. Does it mean it's more effective? Well, that's not actually been shown. Does it mean not in kids or adults? Does it mean it's better tolerated? Does it mean any of these above things? And the answer is, in adults anyway, there's a lot of data showing if you split the dose, that oral and subcutaneous are equal dose for dose. There was a recent study from Germany that looked specifically at oral versus subcutaneous methotrexate in conjunction. And the answer was that actually there was no difference in efficacy. And if anything, the oral patients did better. But I would also throw out there, and this is why it's not a tie, because one could say we have no opinion in that case, because there's very few studies that demonstrate that one is better than the other. But there is an issue, which is, especially with combination therapy, we're giving some of these children 6 shots a month. Not only are we giving them 6 shots a month, we're making parents inject their children 6 times a month.
Yeah.
And if we don't know that it's better, I might suggest that I would err on the side of decreased needles, because there was an article not that long ago that came out. I presented it when I did your interview looking at medical trauma and post-traumatic stress in our patients, and it's high. And I know that they didn't find any difference between injectable medications and non, but if we're taking care of a child who's 2 and they may stay on medicine forever, that's a lot of injections over the course of a lifetime for something that many of us believe to be true, but the data doesn't actually support.
Super interesting, Karen. And then another hot topic is glucocorticoid use. I remember as I was teaching at the medical school, we gave the students the recommendations of treating rheumatoid arthritis from the ACR and EULAR, and they differ. ACR says you shouldn't use glucocorticoids at the beginning because of its many side effects, while EULAR guidelines for adults with rheumatoid arthritis suggested, no, actually you should because it's more effective. Where did you guys come to conclusion regarding the use of glucocorticoids for children with JIA?
It was quite interesting because Susan Chenoy could not come to the voting panel meeting as an observer because we take notes, really incredibly detailed notes. And that was the thing that surprised her the most, was that we came out against steroids. So why did we come out against steroids? We came out against steroids for a few different reasons. I do think in children, the balance is different than adults. It's bad for their bones. They get weak and they don't grow, which is a major function of childhood, is, to grow. And
that is the purpose of it, right?
It is one of the things that they do. Also, I think the objections to biologics in children might perhaps be very different than you see in adults, where as you get older and closer to 65 and above, there are more problems in terms of side effects from biologics, in terms of infections, et cetera. One might say that that's true for steroids too, but irrespective of that, even during COVID, it was not an issue for us to be using biologics. So we really came out strongly in favor of early use of biologics and intra-articular corticosteroid injections when using, and just minimizing. Again, it's a conditional response. So after we came out with these guidelines, I had a very young child I saw in the office who had so many swollen joints. I gave her steroids, and I thought that is the definition of a conditional recommendation. I do it very, very infrequently. The child needed it, and I thought and the parents thought in the best interest of the child that would be appropriate, knowing that we would aim for, as we say, the shortest course and the lowest amount.
Moving on to JIA-associated uveitis. Were
Oh,
there any
yes.
big changes for this guidelines?
So there were two, actually. The first is just that, and it's not really a change, but we really did reinforce, especially for the high-risk group, the young oligos who are ANA positive, that they really need to be screened. It's a strong recommendation. It's interesting because it's not really based on tremendous data, but the missing is so serious. And what is clear in all of the data is that the amount of damage that we get from corticosteroid drops when people present with very severe disease, much of the damage is due to the drops. So the earlier institution of therapy, which is really enabled by frequent screening, clearly leads to the best outcomes.
Mm-hmm.
And since screening is annoying and expensive potentially, but the risk of missing uveitis is so extreme. And as we all know, people don't always follow recommendations. And there is the sort of N-1 school. So if we change it from every 3 months to every 6 months, then people might go once a year. We need to keep this ever present. And as we know, that's a lifelong risk.
Mm-hmm.
So it's very important. So we did really reinforce the need for treating especially the highest risk groups. Obviously, be different, systemic, rheumatoid factor positive, their risk is much lower, et cetera. So we're moving toward risk stratification. We're not there yet. But the other thing that I think the ophthalmologists on the panel were so excited about is similar to the way we wrote the non-systemic J paper, DMARD first. If a patient needs a biologic first, a patient should get a biologic first. They do not have to quote unquote fail methotrexate. And it's an interesting conversation because from a patient's perspective, failing treatment is really a negative concept. The medicine failed me. I don't fail the medicine, right? But you're taking somebody who's losing vision, and what you're saying is, let's give you this medicine that takes 3 months to work with some steroid drops, which you need because the medicine takes 3 months to work. And the steroid drops are associated with all the damage and morbidity that we see. Let's not give you the medicine that is likely to be most effective and get you tapering the drops down quickly, et cetera. Or perhaps you might even need oral steroids to keep the eyes under control, another problem. And so we really, again, are moving towards DMARD's first line as needed. If you need a short course of drops, you can use a short course of drops. But a short course of drops, then you have to move on. And whether it's a biologic or conventional synthetic DMARD is a conversation between the rheumatologist, the ophthalmologist, and the family, not the insurance company.
Great. That makes a lot of sense. So you're basically want to make sure that you don't miss any patient with uveitis.
Yes.
And that you give them the most effective treatment upfront to prevent all the side effects from either the medications or the disease itself. Non-pharmacologic care, right? This is new. I think a few years ago, for the first time for rheumatoid arthritis, the ACR came out with some non-pharmacologic lifestyle guidelines. And this is the first time I'm seeing it for JIA. Is that right?
We had written some last time, buried into the paper. But honestly, we wrote the paper. We did our PICO questions, whatever. Those are the questions of interest. And I had a parent and patient meeting. It was during the COVID shutdown, so it was all online. And, we presented everything to them. And then one of the parents sort of raised their hands and said, it's good that you talk about physical and occupational therapy, mention counseling or any mental health care. And it was like, oh, wow. Right.
Good
Yes.
point.
So we made sure to make some recommendations about mental health screening and really came in strong favor of screening. Everybody's going to have different access to what that screening might entail, but we do know that our patients have high rates of anxiety and depression, and you really do need to keep that in mind, and you need to get them the appropriate help that they need when you notice they're a problem. This is very much in keeping with recently published ACR recommendations and CARA guidelines about mental health screening for kids with rheumatic diseases.
Interesting.
And also with the AAP and the ABP.
So we should screen patients for mental health concerns. How should we think about using physical and occupational therapy? Should that be prescribed to every patient with JIA or?
It's very interesting because I read that statement very different than some of the people on the panel. Because some people read, like, why would everyone need PT and OT? Because they don't. And why can't you just get them better? And why can't you just, et cetera, et cetera? But, I live in New York City, the town of high level athletes. And my big concern actually is as these kids go back to physical activity aggressively, which many of them do, that because they had previous inflammation, that they might have specific weaknesses and be at risk for injury. So I personally view it, of course, as adjunctive. And if they don't want to do it and they don't need it, that's fine. But it should be available across the spectrum of disease, from contractures that need to be worked out to someone who wants to go back to playing, basketball and is at risk for getting an injury across the board. And also a strong recommendation for physical activity. There's still the old feeling that our patients should be reasonably inactive in terms of some of the things that they do. And I remember when I started being told that if you had wrist disease, obviously no gymnastics, but no baseball, no volleyball, no anything that included, the joint in question. And it's certainly something that parents ask all the time. Should I restrict the activity? But interestingly enough, there's really no studies that show that it's better to be restricted than do. Yeah, they get injured sometimes, but so do kids who aren't doing exercise. But we had a very interesting question years ago from someone who is now a psychologist on staff at Lurie Children's. And she said to me, ask your colleagues what they think leads to the most resilient and healthy children with chronic illness. So I threw it out on the bulletin board and I got about 100 different answers, 99 of which were supportive parents and teachers. Okay, which is what I would have said. The one person who answered, who said, by the way, I had JA growing up, just you should know this, said a real life that has nothing to do with illness. Because you need an identity that's not disease specific. You don't want to be the kid with JIA. You want to be the basketballer who might have JIA or any number of different things. So when we restrict our kids from doing normal kid activities, we're reducing them down to their illness. When, as we know, adolescents need to have socio-emotional development that is appropriate for age. And for many kids, that means being the marching band person or the athlete or whatever it is. We need to encourage all of this. So by restricting, which I call parental medicine, which is, that sounds like it must be a bad thing, there's no data for it. So I think that we need to let our kids do what needs to be done.
I couldn't agree with you more, Karen. I think, as we say, motion is lotion. I think all exercise is good, and we should aim to treat our patients well enough so that they are able to do everything that they want to do. Great. And then the other thing that parents often talk about and ask is, what diet should I do? Should I do an anti-inflammatory diet? What about supplements? Should I take, extra vitamin D? Or how did the committee sort of deal with all of those questions?
I think one of the things that we need to discuss with families when they're asking about supplements and special diets is that it really does depend on the age of the patient. So we're dealing with a population from extremely small and underdeveloped to a population that is almost physiologically an adult. And I say almost because really skeleton is not completely set until you're in your 20s. So when we restrict, for instance, dairy, I don't have a particular interest in dairy. We're not baby cows, but we do need to make sure that our children get enough calcium and vitamin D so that their skeleton is healthy, so that later on, when the young women go through menopause, their skeletons are starting from the appropriate density. We certainly don't want to set these kids up for poor skeletal health. Likewise, young children need fat in their diet and they need other things. So we need to just make sure, and I say this to my patients all the time, you need to address that particular issue with your pediatrician. Now, here's a cautionary tale. So there was a young child I was taking care of with polyarticular JIA, whose parents started her on a supplement because they were told it was good. And I've read the literature on this. It certainly is out there as one of the things. And she came and we got labs for follow-up for one of the medicines she was on. And her alkaline phosphatase was a number I had never seen. I had to reach out to my endocrinologist because I was quite concerned. We repeated it. It was quite elevated. And turned out that the supplement she was taking specifically interacted and interfered with vitamin D absorption.
Interesting.
And so she had a combination of transient hyperphosphatasia of the toddler and impaired vitamin D. And so when we stopped the supplement and added vitamin D into her diet, it all went away. So we just need to know that there are unexpected consequences. And I didn't know she was on this. And quite frankly, I didn't know it could cause problems with vitamin D absorption. So I just think we have to think about what might be okay for adults may or may not be okay for kids. And it might depend on how old the child is.
Interesting. And then diets. I know in the adult literature, now the recommendations for rheumatoid arthritis in regards to diet, I think the ACR came out in favor of a Mediterranean diet as sort of guidelines for diet. Any recommendations in regards to diet in children? Or there was just not enough information?
I think what we said was healthy age appropriate. Because again, what's appropriate for a 2-year-old and what's appropriate for a 17-year-old are quite different. The other thing I wanted to say about diet is that a patient came in one day with his mom and said to me, tell her that putting me on a restrictive diet, I hate this diet. So I said to him, honestly, I think families are allowed to decide what to feed their children. I mean, I have patients who are vegan and vegetarian and halal and kosher. In general, as long as it's a healthy diet, I don't really have a feeling about it. And he said to me, I am the only one on this diet. Everybody else in the family can have a cookie. Everyone else in the family can have a milkshake. I am the only one who is gluten and dairy free, etc. And I said to the mom, really? And she said, well, he has the disease. And I said, well, it seems to me from my reading, if I truly believe that inflammation is the root of all evil, and perhaps it is, there are certainly people who believe it causes heart disease, et cetera, then the right thing to do is the diet should be healthy for everyone, as long as it's age appropriate. Because the child said it's unfair. I have arthritis. I get shots. I'm the only one who can't have a cookie. This is ridiculous.
Yeah.
And that really left an impression on me, which is, again, I don't tell people what they should eat at home, but it should be broadly applicable.
And certainly, in a space where there's just not enough data to say that one thing is better than others, I think that makes a lot of sense.
Yet again, it's come to fruition. We're almost done. We're writing the manuscripts. 2 new medicines got approved for children.
So what are you going to do?
So we added, in the medicine monitoring part, we added apremilast and vaselcamab. We put them in terms of how to monitor them as for the package insert. And next iteration, they will have to be addressed when we talk about psoriatic type JIA. This is a blessing because before the 2021 guidelines, we had added, I think, secukinumab and tofacitinib, and now we've added upadacitinib. And now, again, the paper is written, the voting panel is voted, and we have to add 2 new drugs.
Amazing. I mean, but that's what a great thing that these drugs are now being approved for JIA, right? Really wonderful. Okay, so now I can ask you, looking at all these guidelines that you guys came up with, what are the biggest research gaps? Where do you think the field should be focused on to try to answer questions that really matter to patients?
So, as a parent, myself, of now adult children, parents always really want to know the answer of what happens. And I truly believe, now I've done this for a long time. Dr. Lovell said I'm older than dirt, but certainly I've done this before biologics. And I can tell you anecdotally that the children do much better than they did, right? No question about it. When I first started, we did so much rehab and so much canes and crutches and wheelchairs and all of this, which our young trainees have no idea about. So we think we're doing a better job, and that's probably true. But we really actually need to just continue to formally study them. So we have studies that we've done through CARE and other organizations, following forward, et cetera. And these are really going to be crucial because what is clear over the last 30 years of my career is that early treatment is really critical. And we need to know what the best way to do that is. So what we still don't know is Is there a patient with poly-JIA in whom TNF inhibitors are never going to work? If they're never going to work and methotrexate's never going to work, we've now potentially wasted of a child's life. 3 months of methotrexate, which didn't work, 3 months of one TNF inhibitor that didn't work, 3 months of another TNF inhibitor that didn't work. Now they're 9 months into it and they still have active disease. Treated targets suggest 6 months in remission, right? We're not there. So I think for me personally, one set of biomarkers are, could we figure out what drugs are critical up front?
Mm.
That would be helpful, as opposed to just launching through things historically. This is the oldest and the second oldest, and so on and so on and so on. 1. 2 would be, when is the disease actually gone?
Hmm.
Because recent studies suggest that when you stop medicines, you can't always get people back under control in the same medicines. Wouldn't you love to know, as Dan Lovell said when we talked about stopping medicines, when biologically someone is in remission as opposed to just exceptionally well treated? Deprescribing. When is the right time to deprescribe? We all want children to get off medicines in a theoretical way. But what we don't want children to do is go through bouts of flaring and the drugs stop working and we run out of good, safe options because we just didn't know the answer to that. And these are two things that have been really hard, what to give and when to stop. But I truly believe that we'll get there. And those are the things that really, what I wish I had.
Amazing. So what's the team going to be doing going forward in regards to guidelines and updating them? Are you guys already thinking about sort of the next iteration, and how would that look? And when do you think that they would be published?
You know, some of the questions that were important for us to ask in 19 are not really the way we would think about things now. So we're going to take a brief break after we get this approved by the committees, gone through the board, then it has to be peer reviewed for the journal. And we're going to look at the questions we asked and see if we really asked them the right way, because asking the questions helps us do the literature search. So we're going to do a little of that. And then ideally, what we'll do is update these on a need to update basis, because I don't think we realized how much has changed since 2019. Honestly, just not very long ago. But those papers are woefully out of date. And by the time we publish this, I'm sure another drug will be approved and they'll be out of date. But this hopefully will allow us to do this in a more flexible manner so that we won't have to do everything all the time. Bring everything to ground zero. So as of 2026, when these get published, this is really the best we could do. And then move forward in a rolling way.
I can't emphasize how useful this is for us rheumatologists that are trying to sort of struggle with thinking about what are the best medications for this child that I'm seeing in front of me, right? How should I step up therapy? What are the options? What about monitoring? It's so useful to have sort of this backbone. And, you know, like you said, you have to customize everything to the child, but at least having sort of the options available out there, it's really useful. And
But they matter because the insurance company quoted them. But more to the point, and I think we do have to remember this, 50% of the children are taken care of by adult rheumatologists. And there have been study after study after study showing that they are not aggressive as compared to the pediatric rheumatologists. We're just really comfortable prescribing DMARDs for children. We don't want these kids on months and months and months of NSAIDs. We don't want them getting steroids. We want them getting DMARDs. So this is another way of getting it out there so that in locations in the US where there are very few pediatric rheumatologists, and perhaps an adult rheumatologist is taking care of the children, they can reference what is the current best practices so that we can get them to places where they might otherwise not be reached.
Love it. Karen, this has been a wonderful conversation. I can't thank you enough, certainly for all the hard work that it takes to sort of lead the development of these guidelines. And then, of course, for your time here today to talk with us about it. So thank you.
Oh, thank you so much for having me back. Hopefully it's going to be a little while till the next one.
Appreciate it. Have a good day. These guidelines reflect a real shift in pediatric rheumatology. Earlier use of effective therapy, more individualized treatment decisions, and a broader view of care that goes beyond medication alone. They ask us to think not just about controlling inflammation, but about supporting the whole child, their mental health, physical function, and their development over time. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find all of our show notes for this and all other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, let's work together to improve the lives of children with JIA. And of course, stay healthy.
This podcast was edited by Resonate Recordings.